Welcome, and we're so glad you could join us for today's Community of Practice session on Services for Substance Use Disorder, New Hampshire Managed Care Organizations, and Behavioral Health Support. This COP is sponsored and facilitated by the New Hampshire Department of Health and Human Services in partnership with the Foundation for Healthy Communities and the New Hampshire Technical Assistance Center, also known as Growth Partners. We're excited to have you with us today. Now, before we get started, we want to go over a few quick housekeeping notes to ensure everything runs smoothly in today's session. So we just want to remind everyone that this session is being recorded. So with that in mind, we want to keep our microphones off unless we are participating in the program. Also, in line with privacy, if you prefer to maintain privacy, feel free to turn off your camera, totally your choice, but we love seeing everyone's faces in the meeting. If you are experiencing any technical hiccups like audio or connectivity issues, turning off your video might help. You can also double check your audio settings if needed, as we see here in the presentation. Make sure you have the right speakers and microphone chosen for this session. And lastly, we love the engagement and the participation on these sessions. So please feel free to share your thoughts in the chat, use reactions, or engage with the Zoom tools as we go along. Your input really adds to the conversation and discussion. And with that, I'm pleased to hand things over to our moderator, Dan Andrews, from the Foundation for Healthy Communities, who will guide us through today's session.
And that took care of an introduction too. I'm Dan. Let's see, I'm just checking to see as messages come in here, and do welcome today. We have some new faces in our community practice meeting, and that's delightful. I know that Melissa had done some marketing to some other groups, and we hope you like what you find here today. We work hard to provide good content every other month for this community practice session, which lasts for an hour at lunchtime on the third Thursday of even-numbered months. Today, we are joined by two representatives from the managed care organizations that serve New Hampshire. There are three. We tried to get all three, but we had some problems. One of them had some problems with some staffing, but we have two extraordinary representatives joining us today who are not only extraordinary clinicians, but are very committed and passionate about patient care. And it's been a pleasure to work with both of them. We're also joined by Nancy Fennell. Nancy is the director of our Behavioral Health Clinical Learning Collaborative, and we have been working together for over 4.5 years to bring those worlds together because they are together. And I owe so much to Nancy for constantly encouraging me to continue to explore the services of managed care organizations, which is how we got here. Today, we're going to understand more about the services offered by managed care organizations and learn how to access those services. And I'm pleased to welcome Dr. Donald McNally, who is the Medical Director of Behavioral Health at New Hampshire Healthy Families. Dr. McNally is also an addiction psychiatrist, and Dr. Stephen Descoteau, who is the Addiction Medical Director for WellSense. I'll just use the shorter name for that. We've worked with both of these people. Exactly a year ago today, the New Hampshire Hospital Association Board of Trustees passed a resolution which was a call to action for hospitals throughout the state to assure a basic level of care for persons with opioid use disorder. Nancy and I took on that task and set out with several tasks, and within a few months, we were down to the level of working with individual hospitals on whatever kinds of barriers they faced. And nobody could have done more than our partners in the managed care organizations in terms of not only supporting that work, but kind of being right there as peers to the people who are providing these services. They've done so much. And it's with a sense of deep gratitude that I welcome you, and I'll turn it over. Dawn, is it okay if we start with you?
Sure, that's fine. And I'll start. So thank you for having us as always. It's always good to hear. And I think part of this, I'll go over the broad kind of strokes of, what all the M's. So, I think sometimes there's a misunderstanding or just a lack of clarity because there are three separate MCOs. There's ourselves at New Hampshire Healthy Families, there's WellSense, and then there's AmeriHealth, who unfortunately couldn't join us today. And each of us, while different entities, we all cover the same contractual responsibilities and have a lot of the same contractual we have all the same contractual requirements from New Hampshire DHHS, and we act as a hired contractual arm of DHHS and agree that we're going to follow their servicing models. So in terms of, what we basically do as an MCO, and while we all have very little different ways of doing this, we all do cover the large gamut of substance use disorder services, whether those are in a hospital, residential treatment, outpatient, inpatient, IOP, PHP. We follow the New Hampshire benefits guide for that, right? In the way that New Hampshire DHHS wants that done through, a formal ASAM assessment, which we're still using the third version of ASAM. And all of those items have to be covered under that. Each individual MCO also offers additional benefits in some ways for substance use disorder treatment and individuals struggling with substance use disorder. But unfortunately, given that AmeriHealth can't be here today, we run into some stumbling blocks where we can't really promote any other work we're doing outside of this because it gives an unfair advantage, and it actually, the state doesn't like it when we do that without all three or if we're alone. So I won't cover some of those things. The other part is I'll just introduce myself and kind of what I do. The New Hampshire state contract is interesting. It's one of probably 4 states in the US that requires each of their contracted managed care organizations to have a board certified addiction physician on staff. So Dr. Dakota and I are the 2 for WellSense New Hampshire Healthy Families. And, my background is that I've been basically in the treatment world up until joining managed care about 4.5 years ago. And my job largely is to kind of educate on the SUD services, educate on programs that New Hampshire Healthy Families may offer, but also to provide subject matter expertise because these things can get confusing and guidelines change. Working with individuals who struggle with substance use is really difficult, and providing information on MOUD or for any substance use disorder treatment, and really being here for the general community at large versus a representative of the MCO. I am more clinical. I don't do utilization management. And I'm really here for the community and to be a resource to the community as needed, either in person or, wherever I need to be. So I'm always available to you. And I feel like the other MCOs feel the same way. And I feel like I've talked too long now, and I don't want to take any of Dr. Dakota's thunder for now. So I'm going to turn this over to him so he can add whatever I missed or didn't miss or whatever.
No, thanks. That was a great setup, because you're right. There's a lot that all the 3 MCOs do that are common to one another. We're all working together to meet a common goal, to reach a common goal together. So I wanted to echo a couple of things that Dr. McNally said, but I also wanted to thank everybody for having us here, and to be able to help people understand what the different managed care organizations in New Hampshire are doing in the substance use disorder space, and what we're doing to be a resource for the community. And I, like Dr. McNally, I don't do utilization management. I don't do approvals or denials for services or hospitalizations, but I'm here just to be a resource. So a little bit about me. I'm a board certified internal medicine doctor, and also I later became certified in addiction medicine. And I've worked in a number of settings. I worked in a FQHC, a federally qualified health center, as a primary care doc back in the day, and that was 4 years. Great experience. After that, I worked as a medical director for a county jail for 7 years. Also really wonderful exposure to serving the underserved. On the side, I worked at the methadone clinic, which was fascinating. I did that for a year. And I worked in an inpatient program for women with substance use disorders. This was a program in the Department of Mental Health. And I did that for about 2.5 years. I learned a lot about starting MAT medications, stopping them, changing them, and working with also some significantly mentally ill people. And then prior to coming to Carillon almost 2 years ago, I was the statewide medical director for the Massachusetts Department of Corrections, where we launched a number of really fun and interesting programs. So with Carolyn, I've been out and about for about 2 years, meeting with whoever will have me, and it feels a little salesy at times, but I really want to let people know that we're here to provide mentorship, guidance, leadership, and ideas, not patient care, but just sort of ideas for how to make things better. So I visit like peer support organizations, the methadone clinics. I've been to all the doorways and the community mental health centers trying to make connections. I've been to about half of the recovery community organizations in New Hampshire, and those are also fascinating places to learn about what each community has and what they're offering and what's going on and what they're seeing. Back to some of the MCO services, like all of us have some version of provider quality managers where we have folks that can review data that's being collected about performance, about how people are doing with meeting certain metrics that the Department of Health and Human Services finds to be important. And we also will support quality improvement ideas and programs. And we also, all of us provide oversight, particularly with the OTPs, the methadone clinics, where the Department of Health and Human Services wants each of the 3 MCOs to have a continual presence, but also to provide guidance, mentorship, supervision, and audits as required by the Health and Human Services. Last thing I wanted to mention is there's a handful of HEDIS metrics that the state feels is important, and they change every year. And they're kinds of things like we want to make sure that when people are admitted to a hospitalization for an inpatient psych stay, that follow-up is appropriate, or that if a person gets a diagnosis of SUD in an emergency room or wherever they're in a hospital, that medications for OUD or alcohol use disorder are started ASAP, particularly within 7 days. And then other things like we want to make sure that when people start treating patients that they're retained in treatment for at least 6 months. So a lot of what we all do is just to kind of identify, where are things falling through the cracks? Where do we need more connections with peer recovery support? Where do we need more networking with RCOs? And then the last one, and then I'll stop, is this year the Health and Human Services Department wants us to make sure that anybody who started on an antipsychotic medication gets a wellness visit with their primary care doctor to do screening for diabetes, high cholesterol, things that are commonly associated or not uncommonly associated with people on antipsychotics. So we're working to kind of get an educational program together so that people can do more of that and get their patients the care that they need. So I'll stop there.
Thank you both. I'm always intrigued. We work here in sort of the understanding the large landscape of substance use care in order to be effective with our work in moving hospitals toward better care. And you both have been helpful in helping us to understand the contours of that. Any observations from you about what New Hampshire looks like, what we need, and if you see a trajectory forward for our hospital systems as they continue to improve substance care services? Just, very big, you folks deal in the big picture, and I'm just curious about how you perceive the big picture.
Yeah, I know that there's a big push to get more emergency departments to initiate MOUD in the emergency room, whether it's methadone or Suboxone. And there are a number of hospitals that are doing a really fantastic job at doing that. And then there are others that are kind of falling behind. They tend to be places where their doctors aren't the same doctor month after month. They have people, flown in, parachuted in from around the country, and they may not agree or they may not understand that starting medications for opioid use disorder really does work. So one of the things that we'd all like to do is to support programs that are interested in getting this kicked off and providing, evidence-based guidelines that are available on the internet just to help people feel comfortable exploring and extending into this realm of providing medical care.
Sounds good. Don, do you want to add anything to that?
So this may be an unpopular opinion, or it may not feel it on the ground, but I actually think New Hampshire has one of the most robust access and availability to MOUD services in the state in a larger outpatient sense, especially compared to other states I've worked in, either clinically practiced in, or, I found it's been a few years since I clinically practiced in Connecticut, but I found that it's actually much better here and there's more communication. And I felt that I actively practice in Maine, and it's much better in New Hampshire. But there are some gaps, and I think that's where the larger system really needs to work together. And I think these larger outpatient organizations who provide MOUD need to work with both, and we need to somehow bridge those organizations with emergency departments. And what I've found largely is, I don't want to say it's specifically stigma in the emergency rooms, but there's a large component of lack of education around resources, availability, and ease of working with individuals who struggle with opioid use disorder or any substance use disorder, really. And, getting them to that next step, and really just, that's been our major goal of being able to get these systems communicating, because I think that will actually improve the overall system of care across the state. I think it's all, the pieces in New Hampshire are largely there. It's just really getting them all to work together. So I actually think that's really promising, and but it's hard work. So yeah, I could go on for hours, so I'll stop.
Thank you. I just want to take some time here. You all have taken an hour out of your day to see other questions that have come up so far. Just to do a quick check-in. I know several of the people that I know well and work with very well who are absolutely neck deep in this work and who are doing such fabulous work are in attendance today. And just some thoughts from them about the relationships between the major component of the healthcare system that you represent and the delivery system in which they work.
I can comment on that, Dan, if you want. Hi, everyone. Sarah McGuire, Exeter Hospital Core Physicians. So we have here at Exeter a pretty robust cross-continuum MAT program where patients can present to the emergency room, get their inductions, and then we have a process for transitioning them to outpatient. 95% of our primary care providers are prescribing MAT. 100% of our ED docs are prescribing MAT. It's just all these pieces are there, like you were saying, like there's peer recovery support, there's access to PHP IOP. It's the care navigation piece that we are so struggling with here. We do what we can with the resources that we have. But to me, that's the gap. There's no one that has the time to commit to getting patients to the right services that they need, even though they exist. That's been a challenge for us for sure.
Yeah, I almost think that there should be some kind of like substance use disorder care navigation that's done by peer support, like an additional service, and that we could look at ways to either fund or support that, because they're the closest to the ground too. I think peer recovery, I've never worked in a clinic without a peer recovery specialist, so I think I'm spoiled, and I don't think I could ever work without one at this point. But I think they're best positioned to actually help with that and have kind of like a dual purpose in that way, even though they have really important and hard jobs. Adding that might be difficult, but I think there's a component that connects with that, and is really helpful. We had one at the VA who did something similar and did that, and it was really helpful back in Connecticut.
I would agree with that. When there's peer recovery support, people in the hospital or in the emergency room or in the system, things go a lot better. A lot of times it's difficult for the more rural areas or some hospitals that don't want people in that aren't employees. It can be a barrier to kind of getting people in there. But I'm a firm believer in the peer recovery support system. It's super helpful.
Yeah, we use SOS as our peer recovery support. We have them on call 24/7. for our ED and our inpatient units. It's just and they're great navigators. There's just a disconnect when it comes to what happens in the emergency room and what gets back to primary care.
We had a question in the chat, and this comes from Jane, and she said, what happened to the initial mandate that there be a LADAC or an MLADAC attached to the MOUD program? Jane, I'm not familiar with that particular issue. Would you like to come off mute and talk more about that? And Lori is responding, the problem is that Medicare will not pay for a LADAC or an MLADAC. So while we're waiting for Jane, Nancy, I thoroughly enjoy your monthly sessions, and you're always calling people in, and I'm going to turn the tables on you because you've been deeply involved in all this work. And she's shaking her head, and I'm going to pay for this 1 minute past 1. But any thoughts from you?
Sorry, I had to jump off for a call from one of our hospitals, so I missed just the last part of this. But I think that one of the areas that I'm very interested in focusing on is what we're finding, and the evidence shows that at least 80% of our patients that are struggling with some sort of alcohol or substances challenge are also struggling with mental health issues. And so alongside the peer recovery support services, I also see the ability to add in peer support from a mental health side of things. I call it the Yankees and the Red Sox, because it's trying to get the two to really start working hand in hand with one another. And I would love to hear from the providers on this call what your thoughts are with all of that.
You want to call somebody in?
Well, Sarah, I know I caught that you were using SOS, but that's all I caught. And then I had to grab the phone. So just wanted to hear how that's going.
Our relationship with SOS is great. I don't think we are consulting them for every patient that should have a consult. So I think that we're missing folks, and a lot of that for us is like digging back through the chart, seeing who we missed, why they got missed. So that's, getting them, we do about, I would say 15 on average SOS consults in the ED or inpatient per month. We also have a process on the outpatient side where we can automate a referral sent to them so that they'll do outreach to the patient, so that it's not like, okay, patient, here's a number you call, because that's very impersonal and very often that gets lost or they don't call. So we do proactive outreach with SOS for our outpatient folks. But everyone that's engaged with them, for the most part, has had positive things to say. We do get a report back every month of just like a brief description of what happened with that patient. But a lot of times it's just like a one encounter and done. If the patient doesn't continue to follow up with them for whatever reason. And it would be, I guess, really nice to have some sort of like ongoing coordination with them for patients that are maybe not ready to engage in recovery now, but working through SOS, they're like, a light bulb goes off, SOS is like, okay, they're ready, let's get them in with primary care today to start them on MAT, because we could accommodate that, it's just we don't always know. You got to take advantage of those windows.
Monica, I see you nodding, and at Concord Hospital proper, you don't have and I'm gonna, as I was accused of, I'm gonna call you in on this. I'm not gonna call you out. I'm gonna call you in on this. But a fantastic program up at Laconia and Franklin with navigating recovery. And Dawn's nodding because you've seen it, but at Concord proper, what are you doing there?
So, yeah, I think it is that is a complicated question, but let me see if I can explain it. So, I'm the director of substance use services for Concord Hospital. And I report to Lisa Madden, who's the CEO of Riverbend, because we have a partnership. We're very collaborative. So I actually, as the director here at Concord Hospital, report to Lisa Madden. And our doorway contract with Concord Hospital, because our ED is a very, very busy ED. Mental health is, right now, I think, there's 6, 8, which is small, people waiting for beds either at New Hampshire State Hospital or Hampstead, unfortunately. So so our doorway is down the street a little bit. My staff, we do the consultation. So, and then we do the warm handoffs to the doorway. So we're going into the ED and meeting with patients, trying to engage them, and then get them into the doorway. I think or somebody just mentioned the co-occurring and, folks. And that is a tough population. Because some of them, we're just trying to just get them to engage and just, have a conversation. But a lot of them are not really, they keep coming back. We can't get them to even get in that taxi to go down to the doorway. Or we have the doorway up a couple mornings a week too, involved with the ED. With those patients, so that if they're identified, we're trying to get them seen as soon as possible. That's going to change too. We also do a lot of, like I said, a lot of inpatient consultation. I think last month we did about 91, my staff did last month. So that's how the doorway is structured right now, or how we engage folks that are in the ED. So I have a staff member, we don't get paid for that consultation, that goes throughout the hospital too, so the co-occurring is a challenge. I'm a psychiatric nurse practitioner specialized in addiction. I wear a hat down at Riverbend in their Choices program. That's the population I work with. It can be very challenging in treating them, as you guys can only imagine, trying to tease that out. Is this bipolar? Is this PTSD? Or is this just part of their protracted, opioid use disorder that I'm still trying to get stabilized? So, but keeping these people engaged is really hard. And the time that goes into the care management, that's and when we're not reimbursed for that. The care management, whether it's a peer, whether it's me, whether it's someone else doing that work, that's, it's a lot of work that is not at all direct care, so it's not billable.
Right. And so this goes back to Dr. McNally and Dr. Descrow. What kind of role can your care management play in any of these situations? Or can you?
So our care managements, all 3 MCO, I should speak for all 3 MCOs in general here, and then let Dr. Dakota take it. We all have care management staffs, and they're quite large, and they have the availability to work with any members of their individual Medicaid plans, right? We're all Medicaid providers. And they have the ability to assist with care coordination, care navigation, assistance with transportation. We do have housing. Some of the MCOs still have housing coordinators on staff. It was struck from the contract. Some still kept housing specialists on staff. So we have those services available to anyone, and either members, providers, or anyone else can call the member services line and ask to be engaged with care management. It's pretty straightforward. There's really no wrong door to that through the way, and they'll get contacted right away and work with that. the state in the new contract, which just started September 1st, care management used to sit 100% with each of the 3 MCOs. So we had very large, they have moved away from that. They want a lot more of the care management to be in the community. So they've kind of changed the way they want that done. And they're empowering primary cares and other organizations to take on more of a care management role and being reimbursed for that, obviously. So that hasn't changed the fact that all of us still have care management staffs who also can do that work. So it's really kind of expanded it so that there's more availability across there. I don't know if you have anything to add, Steve.
Only that I think we could do, at least on the WellSense team, we could do a little bit better at increasing collaboration between our care managers and the care managers of other teams. Like, I'm encouraged by what's happening with this new 1115 waiver demonstration discussion, where as people are getting out of prison in their last 45 days, our care managers will work with their prison care managers to make sure that a good plan is put together. And I think that's a model that should be spread out so that our care managers are better connected with primary care offices or with methadone clinics or with community mental health centers, so that people can help each other.
How do you see this happening then? What are your recommendations? I'm sorry, and I know you've got a couple of things going on in the chat, but I think this is really what this conversation was supposed to focus on, was how can we, and sorry, no offense to the 2 docs at the MCOs, but how can providers take more advantage of you? It's really that's what you're there for each and every patient. And the other thing that I want to know about is how can we better educate the providers on what services are available to them that they can bill for?
I think that's what it comes down to, is that we need to be better at not selling it, but just sort of saying what's available, what's out there, and what's billable, what's reimbursable. I know this is a slightly adjacent topic, but like the peer recovery support agencies, like there are billable codes out there for the services that they provide in 15-minute increments. They're not using them, and I think probably it's a burdensome process to do the documentation and submit claims and all that kind of stuff. So they're just not doing it, and I wonder if we should promote more use of that or things like that.
Sorry, Dan, taking over. Oh, sorry. Go ahead, Don.
No,
But,
I mean,
Sarah's question too.
This is, I think it's been an internally frustrating issue for, I don't know, 4+ years for me, that every provider who comes in network with us, and it's required that we provide them a provider orientation, every hospital, and all of this information is given to them in slide decks and but practices are just so busy that it's really hard to get that right. In my practice, I couldn't deal with this. And so, I think we have to figure out how to overcome that barrier of getting this information. And we do it in little pieces at a time, like this, and one-on-one, and when I'm out at places, and I'm sure when Dr. Dakota's out at places, he talks about this. It's just so hard. And even though it's helpful, and corollary to this is, there is now an MCAP child adolescent psychiatric consultation line that's live in New Hampshire. And every primary care practice and every pediatric practice I've ever been to asks me questions as a psychiatrist. How do I manage this medication? How do I do this? And I've always wanted an access line. Now we have one. It's been active. It's less than 6 months. They've had 14 calls total. Connecticut access line gets 400 a quarter. We've had 14. And so it's just really hard. And providers can bill for this. It's just they're so busy and so overburdened at this point. It's hard to even get them things that will help them. So I don't know the answer to that. I wish I did. If someone on this call does, please.
Yeah, we've had similar kind of discussions with our teams about, how much communication is too much communication. Like, people don't want a mailing, they're not going to read it, they're going to throw it out. Or should there be an email, or should there be a newsletter that goes out once a quarter that sort of champions these programs that are going on, or new programs that are emerging, or how to connect with our care management team. So it's an ongoing challenge.
Sarah, do you want to ask your question?
Oh, yeah. I mean, it's something we've been struggling with here at CORE for a long time. Social work is very much a mission-based service that we offer our patients. And, you know, I saw the changes coming out for reimbursement through Medicare for collaborative care management for patient with chronic conditions. But what we find is that most of these patients, they're struggling with social issues, not nursing issues. And we have 1.5 FTEs for social work for 70,000 patients, and it's not enough. And there's no way that I can develop an ROI for them because we can't reimburse for them. And I hear there is a reimbursement for doing social determinants of health screening. However, in practicality, the patient still needs to spend, 16 minutes with a provider in order to bill for that service. The provider needs to document it. And I'm like, I can't ask them to do one more thing. Even though they probably would, because they all want social work so bad. It just, putting that into practice is really, really hard in a large primary care office.
I'm not the expert on this because I'm just, a psychiatrist. But the primary care first model that the state is rolling out, I was speaking with, the CMO from the state, and really they're looking to fix that for you in a certain way. And again, I'm not the expert on this, but to provide and allow the services to be a larger integrated team. And it's going to take some time, and there may be some upfront costs, but eventually that'll be brought in the back end. Again, I don't know all the ins and outs of that program, but I think that's something to continue to explore, especially with DHHS as they roll out those models and provide education on how to best deploy and utilize those resources to maximize what can be done, right? Because in the end, we want to do more for the people in front of us. Reimbursement's just how we do that in the end. So I think the primary goal is to get that. So yeah,
Can you speak more on that? Because we did primary care first, Medicare primary care first. We were a demonstration site for the last 2 or 3 years. We ended up dropping it because of some data methodology issues that were happening. Are you saying that DHHS is doing that for Medicaid as well?
They are. They just started it on September 1st, and they're working on implementing it now. A new contract period started for all of the managed care organizations September 1st. So it's been about a month, and they've been slowly rolling that out over time in the codes and reimbursements. And so that's something that groups in general, the managed care organizations, DHHS, will be providing more education on as they start to implement it. And my understanding is after the first of the year, they're going to slowly do this over the course of the next several months. Again, I'm not the best person to ask. I just know about it because through our work.
If you had a contact, I would love to hear more about that.
I can see if we can.
Subject matter expert on
Yeah,
speed
we
dial.
can see if we can get someone. Yeah, I can see who they, we can see.
Thank you.
Just backing up just a bit, Dawn, you put something in the chat about some of the practices and groups recover together and better life partners, and about how that progresses, and once or twice a month group meetings. And Lori had posed a question asking you to elaborate on medication being managed in a group setting. Lori, did we cover the context well enough there? Not hearing back from Lori, so I'll just, Dawn, do you want to?
He texted. Steve, I don't know how much experience, if you want to take, I can. I've done group medication management for years now, so.
Yeah, I don't have any special insights on that. Sorry.
Okay. In general, Lori, I don't really know how in depth you want to go with this, but in general, based largely off the Vermont hub and spoke model, probably about 5 to 6 years ago, a lot of medication management for MOUD, specifically just medication management group therapy, transitioned to the group setting, and each state has individual limits on how many people they can have in each group. And that's generally how it's done. And it's really based off a model from New York City in like the 90s for CMHC models, where they grouped individuals with the same diagnoses, same medications, and tried to group medication manage them to kind of provide wider access, right? If I'm seeing, you know, I can't see 8 people in, you know, the course of an hour, but I can see 8 people in the course of an hour in a group and do the same type of things and ask the same types of questions. So largely that's how it's done. In group medication management is the model for both BLP and groups recovered together. But it's also the model for like for Maine behavioral health care, all of their what they call IMAT hubs, I can't even integrated medication assisted treatment hubs. They also do all of their medication management in group settings specifically for Suboxone. So that's just more the opposite. That's how I've always worked it. The only exception that I've ever had is I saw patients individually for Suboxone at the West Haven VA in Connecticut. That's the only time I've not managed it in a group. I hope that answered your question. I don't know.
Yeah, interesting stuff there. Thank you. This is taking some different directions and is a little more organic than some of our typical presentation Q&A format, but it's great stuff. Thank you.
Yes, thank you
Other
very much. I
questions or
appreciate it.
responses here? I wanted to. I've been having Jane is having some audio problems, but is posing some questions. And posed one in the chat about some concerns about the MAT program with which Jane is affiliated, and I'll make sure if we don't answer those in this meeting, I'll circle back and do what I can to answer that. But Jane's having some audio problems. That is so.
Dan,
Yes.
I was going to ask a question. How is their integration with the harm reduction coalitions and the MCOs? Is there any tie between the two in engagement?
I don't have one on the Wellsend side, but I would be happy to explore that. Sounds like a great idea.
Oh, Don, you're on mute.
Sorry, I try to go on mute because I have a cold, and if not, you hear me coughing the entire time. We do have a relationship with the Harm Reduction Coalition. We contract with them. They do both internal staff trainings, and they also do our trainings externally on harm reduction services and just basic general harm reduction principles. So we do give that with them. Yeah, and we work, right, we all do different things in harm reduction. I'm currently serving on a harm reduction echo for New Hampshire and Maine. So, I think we try our best to do harm reduction. There's certain appetites with the state and limitations about what can be done, unfortunately. I'm quite harm reductionist in my views, probably on a very liberal side of that. So it's hard to weigh those. But yeah, we try our best among all of us.
I'll jump in. I'm on the board of the Harm Reduction Coalition and am working aside from my board position with the leadership of that group and also with some healthcare providers here to continue to update. But one of the major initiatives has been doing a digestible course. We talked about how difficult it is for people who in very, very busy practices and with huge patient care responsibilities, and trying to do some bite-sized training programs that will introduce and expand upon harm reduction. But yeah, it goes on. But like everything else, it is still a work in progress. Other questions or thoughts while we have this absolutely stellar group here with these great presenters? Anything from Helen or Mark or anybody there that I have missed?
Hey, Mark Goranson here. I'm with the Addiction Recovery Coalition, New Hampshire in Milford. Previous to this, I had worked on a PHP Bridge Street Recovery that was in Bennington, New Hampshire. And we took co-occurring mental health and addiction. And we had people on MAT, and I ran into a horrible problem with transportation. The only provider for a lot of folks to call under these insurance was CTS, and their dependability and reliability was iffy at best. And I'm speaking more in rural areas where it's harder to get there. I mean, I was halfway between Manchester Clinic and Keene, New Hampshire, but it was still a 50-minute trip just one way to that. I was wondering if there's something available in these rural areas or that has been working on, and if CTS is still in business to provide that service.
I know CTS is out there, and there are some issues, particularly like with methadone clinics, like needed to come and dose and then stay for an hour for their counseling session, and the driver's like, "We're leaving right now, so you can either stay here and do your counseling, or you can come home with me." And there's other, or I can drive you home on my van. And there are other, issues about some sketchy stories that are anecdotal, but when you get out into the more rural regions, like even if there was funding for Uber and Lyft, there just aren't any Uber and Lyft drivers that can pick people up and drive them. I know that there are, like one of the RCOs that I visited in, I think it was Keene, they have a vehicle that was donated to them, and they drive people to methadone clinics, to doctor appointments, and they're a big part of it. So I'd be great if we can get more resources to the RCOs to get a van, or improve their ability to help with transportation.
Transportation has been an issue for at least 5 years, if not longer, with the MCO. We all contract with different, I think two of them use CTS. One, we use a different one at New Hampshire Healthy Families, but I can't say that the issues aren't different. I think there's the workforce shortages with drivers, and it's a small pool, and so they kind of all go between the same places. And, I think we all try to combat this the best we can, but I think a lot of different places are utilizing different things. Like they're going to have a mobile methadone van coming for one of the clinics in West Lebanon, so to service, kind of that Vermont border area. But we're trying our best, to squash these issues. But like Dr. Dakota covered, there's a lot, especially in rural areas, because the network just isn't as large. But if you do have transportation issues, you can always call us, or if you have other concerns, you can call the managed care organizations, and we generally have transportation coordinators on staff who can work with individuals on those things to see if we can make it better for them.
Thank you.
Thank you, Mark. We have about 5 minutes left in the this engagement part of our community practice meeting. Are there any other issues or things to bring up? And Jane, I'll follow up with you a little later on this afternoon, and so I can get a better understanding of context and get back with you. Anybody else? Any not quite closing thoughts, but close?
Dan, I had another question for our MCOs. We're seeing a drug trend of crystal meth that's just really staggering on the Seacoast area, at least. I don't know. How do you guys keep up with the, sort of the newest, latest, greatest drug of choice, polysubstance use, and still be able to try and provide medical care to those that are in really active addiction? I'm just curious how you manage that.
Well, it's an interesting phenomenon that, crystal meth use has had regional pockets throughout the country, and it's found its way, sounds like, to the Seacoast area. And one of the most alarming things is that sometimes the meth can be contaminated with fentanyl. People don't know that they're using it, and they're overdosing. The science isn't great on treating crystal meth addiction. There's like contingency management where you incentivize people to stay clean, and healthy rewards cards, or even just financial stuff. But there really is no medication outside of like off-label use of like Wellbutrin or naltrexone. So it's a challenge.
Yeah, I think it is challenging, and I think part of our roles, both Dr. Cotto and I, is to kind of stay up on the latest treatments, kind of understand the trends, the general trends. I think methamphetamine has been much more popular in Maine for a longer time, and I'm guessing it came down through that way. But ASAM actually just provided a great new resource on this. It's called, it's like an algorithm and a treatment guide for people with stimulant use disorder. So that guideline's right on the ASAM website. And they did a great job of kind of encapsulating what Dr. Dakota just covered with, kind of off-label medication use, contingency management. And, it's something I think all addiction providers or physicians look at often to see where the latest on that is. And I've always had trouble treating it in my own practice still. So yeah, it's a tough one.
I would love to get the reference for that. I'm always on the lookout for new and great
I'll look
resources.
for it now. I'll look for it now and put it in the chat if I can before we wrap up.
ASAM has some great resources. Any other questions or comments as we prepare to close?
Just that you mentioned ASAM. We're bringing ASAM actually to New Hampshire. They'll be here November 7th, training on the 4th edition foundation. So we're getting there, and then we'll do a follow up with their skill building. But they are a great resource. I'm so glad you mentioned them. Thank you, Dr. McNally. And yeah, and it's free. So
We have staff attending that event. So
great.
I'm going to that event. I can't wait. I'm excited by that. 4th edition is it's great stuff. And I'm not a clinician, but anyhow, if there are no further questions, that's my cue for Dan to hand it back to Danny for some closing comments around the resources that are offered. That will very shortly include a recording of this video. If there is information to which you need to refer later on, or if this would be valuable for others to see, please do feel free to engage that, and it will be up on the NHTAC website. So Danny, it's all yours to close us out.
Thank you, Dan. Thank you for guiding us through today's discussions, and a big thank you to all of you for the comments, questions, and contributions. As we wrap up today, as mentioned by Dan, don't forget to visit our nhtac.org website to find today's resources, view recordings of past sessions, as was mentioned, and also check our upcoming schedule and join the COP. Our next meeting will be on December 19th at noon. So be sure to mark your calendars and register for it. And lastly, please take a moment to complete our evaluation poll. I'm going to put the QR code, but also for those not able to scan this QR code, I put the link in chat. Your feedback is essential to help us improve these sessions. Thanks again to our presenters for sharing their insights, and to all of you for being a part of today's COP. We look forward to seeing you next time on December 19th. Enjoy and have a great day.